So this is a continuation of some of the talks that I've given, and I think you've attended maybe one or two of them. But the title talk is Addressing Unreliable Research, and I'm going to start off with the second slide, please. The tweet. So, unreliable medical research, not cancer or AIDS. The biggest healthcare problem that our generation needs to solve. Just behind that statement is that we cannot cure cancer or any other disease if we cannot rely on the research being performed to study those diseases. Next slide. Okay, so these are the recommendations. If you open Harrison's Internal Medicine textbook from 1978, these are the recommendations for management of a heart attack. So, 1978, they say that if you're taking care of a patient who just had a heart attack, the following are required. Get that for 6 weeks. Toilet use will only be allowed after food. No beta blockers. Stress prophecy. No angiography because you are dealing with an unstable plaque. And you have to give oxygen to all, no matter what their oxygenation is. In 2015, we don't do any of this. And this is a good example, next slide, of what we refer to as the medical pendulum. So a treatment or a test is considered beneficial 1 decade. Then after a few studies, then treatment or test seems of no value or even harmful the following decade. And we have tons and tons of examples of medical pendulum. I listed here some of those examples. The first is the use of a pulmonary artery catheter or a swan-gas catheter in the intensive care unit. When we were residents with Wally and Ray at Cleveland Clinic, I remember every patient who gets admitted to the ICU will get a swan-gas catheter. And we thought that that was physiologically sound. It was helping us take care of patients. So it was implemented to all patients, even in the absence of a study showing that it is beneficial. And it took a while until like the late 1990s when people started questioning the value of one-gas or pulmonary artery catheterization. Another good example of a complete turnaround is the use of estrogen for women after menopause. Again, when I was a resident in the 1990s, we thought that estrogen replacement is good for women after menopause to prevent osteoporosis, to prevent heart disease. But now all the studies are showing that that's not the case, and there could be some harm with the use of estrogen after menopause. Another recent example of medical pendulum is control of blood sugar in type 2 diabetics. Before we thought that if we could bring down the blood sugar to as close to normal as possible, then the better the outcomes. And then the Ford study got published in 2009 saying that maybe trying to push blood sugar to within normal range could be harmful to patients with type 2 diabetes. They actually saw more complications when the blood sugars were better as compared to moderate control of blood sugar. So there are tons and tons of examples of this turnaround, not just in internal medicine, but also in other specialties. Next slide, please. I have touched upon the topic of unreliability of biomedical research in the past. This article is the most downloaded article in PLOS Medicine. It was authored by John Diaz. The title is Why Most Published Research Findings Are False. And in that paper, he estimated that about 50% of the research that we read in biomedical journals are probably flawed. And there are other factors that are contributing to the unreliability of research. And I've listed some of them. The first one is there's too much emphasis on sensational discoveries instead of focusing on reproducibility of the research. Negative studies are less likely to get published, we know that. And this culture is very much propagated by the academic incentive system, not just in the developed world, but also in low and middle income countries. There are other reasons why the reliability of research is in question. Next slide. This is just a mapping of the biases that exist when you look at the millions of publications in PubMed. And some of them are not intentional, but they exist and they do affect the findings we conclude from those studies. Next slide. So clinical trials are the cornerstone of evidence-based medicine. A study in the early 2000s found that among clinical trials that are published in the highest impact journals, about 3 out of 4 are sponsored by industry. And it's very difficult to remove conflict of interest when studies are being sponsored, are being funded for by pharmaceutical companies or medical devices. Other problems with clinical trials are as follows. The first is that important subgroups are typically underrepresented in trials. So we typically exclude very old patients, we typically exclude patients who have a lot of comorbidities. Minorities here in the US are typically excluded, but they are not enrolled as often as white patients. The low-income, less educated, or low-literacy patients are not typically included in the patient cohort. And for that reason, we can't be guaranteed that the findings are generalizable to those patients. Another limitation of clinical trials is that we see that the findings are too broad and at the same time too narrow. They're too broad because for the most part, you are measuring an average treatment effect. And it's difficult to say how that average treatment effect translates to individual patients. And they're also too narrow because, as I stated earlier, the trial population may be very selective and they may not represent the larger population that you want to target. Next slide. A bigger issue, of course, is the conflict of interest that I had mentioned earlier. This is a paper that was published in 2000 in JAMA, one of the highest impact medical journals. And in this paper, it said that early treatment using Tamiflu reduced illness duration of influenza by 30% and severity by 40%, and potentially could cut down hospitalization rates among high-risk groups. Next slide. A few months later, another study was published in Lancet, another high-impact journal. And they reported a randomized control trial that demonstrated the benefits, again, of your anti-flu medications in terms of alleviating symptoms, decreasing viral load, and improving health and activity. Because of these papers, with the threat of a pandemic flu in maybe like 2007, 2008, governments stockpiled on this medication, Tamiflu, Relenza, because they were afraid that there will be a lot of complications and deaths when a pandemic arises. So they trusted these publications in high-impact journals. And it took 14 years for us to find out the real deal with Tamiflu and Relenza. 2014, after there were some questions about the efficacy of Tamiflu and Relenza, the Cochrane Group demanded that the pharmaceutical companies release all the clinical trials that they performed looking at Tamiflu and Relenza. And when they combined all these trials, what they found was there was no truth to the statement that they reduce complication rate, they reduce death rate, and that they prevent transfer of flu. So the only benefit that they found when they had access to all the trials was that the treatment reduced the symptoms by half a day. There was no evidence that it reduces hospitalization or mortality, and there was no evidence that these drugs prevent person-to-person spread of the virus. So where is the accountability there? The government spent billions of dollars because they relied on those publications from the high-impact journals. And 14 years later, we find that those were all flawed analysis. Next slide, please. This is another good explanation of why we have to be skeptical about what we read in even high-impact journals. So the way we design trials, we're bound to see a lot of false negatives and false positives. So if you look at the diagram on the left, say for example, you have 1,000 hypotheses, and say our base rate of true hypothesis is 1 out of 10. So that means there are about 100 hypotheses that are correct. So for example, our hypothesis is that treatment A is better than no treatment for a certain disease. So if we have 100 of the hypotheses being true, there are about 900 that where the hypothesis is not correct, meaning treatment A will not improve the outcome of a certain disease. The way we design trial, we usually design it with an 80% power. That means that it will detect 80% of the true positives. And also we set the level of significance at 5%. That means that we will see a false positive rate of 5%. So going back to our example of 1,000 hypotheses, of which 100 are true, of those true positives, we will detect 80 of them. So 80 of them will really show a benefit of the treatment. 20 of the positives will appear as negative because of the way we set the power rate at 80%. Now let's look at the 900 negatives. Because of the 5% false positivity rate, we will see 45 negatives turning as positive because of our 5% level of significance. So if you read a paper that says that this intervention is beneficial to a certain disease, the chances that that's true is actually down to 66%, because we have 80 true positives and 45 false positives. So if a paper says that this is a positive test, it's only true in 2/3 of the time. In 1/3 of the time, it is likely negative. I will try to explain this a little bit in simpler terms to really drive the point. Next slide. Let us use the example of an alcohol breath test. An alcohol breath test is now our representation for a paper. So say for example, the alcohol breath test has a sensitivity of 100%. It will detect all drunk drivers, but it also has a false positive rate of 5%, meaning that 5% of positives are actually not drunk, but they test positive using this alcohol breath test. So my question is, if an alcohol breath test is positive, what is the probability that the person is drunk? Next slide. It is not 95%. And I'll explain to you why it is not 95%. Next slide. correct answer is it depends on the base rate of drunk drivers. And in the same token, the true positivity of a study depends on the base rate of how many true hypotheses. So this is the explanation. If the base rate of drunk drivers is 1 out of 1,000 drivers, so we know that there's a 1 true positive, and that will be picked up. That driver will be signaled as positive by the graph test. But of the 999 drivers who are not drunk, if you test them, 49 of them will actually test positive because of the 5% false positive rate of the alcohol breath test. So that if an alcohol breath test is positive, next slide, the probability that the driver is drunk is not 95%, but now is only 2%, because that's 1 true positive divided by 1 true positive plus 49 false positives. So this is what I mean about the base rate really affecting the accuracy of the positivity of the test, or the positivity of a journal article. So next slide. So just going back to my previous diagram, this explains nicely why if the base rate of true positive hypothesis is about 1:10, then if you see a positive journal, you have a 2/3 chance that it's really true positive, and there's a 1/3 chance that it's actually a false positive, and that would change the reliability of a paper saying that this test is truly beneficial, or this intervention is truly beneficial, will change the base rate of how many hypotheses are typically true in your particular specialty. Next slide. I want to introduce this concept of fragility index. And I think this will become a common metric that we will be measuring for every randomized controlled trial in the future. Next slide. Fragility index is not that difficult to understand. So say, for example, you're comparing treatment A and treatment B, and the finding of that study says that treatment A is better than treatment B because treatment A had less deaths or had improved outcome of some sort that was measured in the study. And fragility index is the number of patients that will remove the significance. So for example, if treatment A is better than treatment B at the level of significance of less than 0.05, how many patients would it take? For example, if we have 5 deaths in treatment A and 10 deaths in treatment B, how many patients, how many change in outcomes would it take so that the p-value becomes no longer significant? So that is the fragility index. So the bigger the fragility index, the more robust your finding is. So there's this study that actually looked at 400 of the most influential papers featuring a clinical trial in the highest impact journals. And what the authors did was to look at the fragility index of these top 400 papers in New England Journal of Medicine, Lancet, JAMA, Annals of Internal Medicine, and British Medical Journal. Next slide. And what they found is that half of the papers had a fragility index less than 4. So it will take 4 patients to completely eliminate the statistical significance of the conclusion. And worse, they found that in more than half of the studies, there were more patients who got lost to follow-up where they did not know the outcome. And the number of patients who were lost to follow-up was higher than the fragility index in more than half of the studies. So that tells you how fragile these studies are, of how reliable they are. And worse, majority of them are never repeated. We take them at their face value. We embrace them as truths in the practice of medicine. Next slide. So evidence-based medicine came about in 1990, and since then, we have been trying to publish evidence-based guidelines. Are they really evidence-based guidelines? Next slide. So Medicine issued a report looking at all the clinical practice guidelines that are available in the United States. And they had experts weighing in and appraising what is the, how strong are the guidelines in terms of evidence. And the conclusions of the report are as follows. For many clinical domains, high-quality evidence is lacking or even non-existent. And often they rely on low-quality evidence or expert opinion. And let me give you two examples. Next slide. This one comes from the American College of Obstetricians and Gynecologists, and they reviewed all the practice bulletins that they have published. This report was released in 2006, and their conclusion is that less than a third of the recommendations by the American College of Obstetricians and Gynecologists are supported by good and consistent scientific evidence. Next slide. What about the American College of Radiology, American Heart Association? Again, they did the same thing. They looked at all the guidelines coming from both organizations, and what they found is that only 314 recommendations of a total of 2,711 were classified as having high-quality evidence, with a median of 11%. And the rest are primarily expert opinion or evidence supported by weak data. Next slide. And for our colleagues in low and middle income countries, it's even worse because most of the time guidelines are adopted from the countries where research is being performed. So the repercussions of these guidelines is magnified because they are implemented with some customization that's typically based on expert opinion, and they're being used among populations who are not even involved in the original research that was done. So how can you say that the American diabetic guidelines are also the best guidelines for the patients in the Philippines? Next slide. So there is some light at the end of the tunnel. So we feel that digitalization of healthcare data may provide a solution to the problem of adopting guidelines developed in high-income countries. So with the increase in the adoption of electronic health records, we now have the capability of looking at what works for our own patients. We now could perform our own analysis of whether treatment A is truly better than treatment B for our patients in the Philippines. And we no longer have to follow the guidelines coming from other countries. But it's not as simple as that. Next slide. The biggest concern is that with more data, we will have more noise. We will be polluting the biomedical research with more unreliable research. And the next couple of slides are just examples of the pitfalls of this so-called big data phenomenon. So the next slide looks at whether, so this group of investigators found almost perfect correlation between the spending of the US government in science, space, and technology and the prevalence of suicides by hanging, strangulation, and suffocation. And if you don't know anything about these topics, you would think that one is the cause of the other because they align very, very well. So when you look at this and when you perform the analysis, the conclusion that you're going to say is the more we spend on science, space, and technology, the more people are going to hang themselves or strangulate themselves or suffocate themselves. And these are some of the dangers of big data analysis. We are going to find a lot of spurious correlations. Next slide. This is another example of perfect correlation between the divorce rate and the consumption of margarine. They look very similar. If you perform analysis, they will say that these are perfectly correlated. And it is very tempting to say that couples are more likely to be if they eat more margarine, but we know that this is not true. Next slide. This is a paper from the American Journal of Clinical Nutrition, and what they did, what the authors did was they opened a popular cookbook, they randomly selected 50 ingredients, and they wanted to ask how many of those are associated with significant increase or decreased cancer risk in the scientific literature. And what they found is that almost every ingredient has been associated with cancer, if you look at PubMed. And it's really very difficult to see which studies could be relied upon, which studies are true positives and which studies are false positives. So with those, and our group is very much in the thick of the big data analytics in healthcare. What we decided to do was to hold a critical data conference at MIT and bring together thought leaders from academia, from industry, from the government to discuss the pitfalls and challenges of health data analytics in this era of electronic health records. We brought together the data scientists as well as the clinicians to pitch in and participate and contribute to these discussions. Next slide. We were fortunate to have two keynote speakers. The one on the left is Jeff Brazen, who is the editor-in-chief of the New England Journal of Medicine. So he is the poster child of biomedical research. And on the right, the other keynote speaker is John Leedis, who is the biggest critic of biomedical research and who is really the father of this unreliable research movement. And the take-home messages of the conference were as follows. Next slide. The value of large amounts of data hinges on the ability of researchers to share data, methodologies, and findings in an open setting. And if this value is to be gained from the analysis of retrospective data, we need to have a more continuous peer review that should be created by groups working together on similar problems. So, next slide. This past year, we have been organizing datathons. And datathons are weekend events where we bring together clinicians and pair the data scientists, including those who in statistics, immunology, and machine learning, and signal processing. And together, they interrogate the database for questions that frequently are encountered by the clinicians in their day-to-day practice. And this is a research model that we think will be more and more popular. It brings together required experts from different fields in a venue that espouses constructive collaboration, group learning, error checking, and methodological review during the initial design and subsequent phases of research. And we want more clinicians to be involved in creating the knowledge base. We feel that the clinicians are the ones who are immersed in the practice so that they are most familiar with the information gaps. And they are the ones who should play a central role with assistance from the people who are experts in data science. So here we've held the datathon at MIT, in London, in Paris, and next year we're actually going to Melbourne and Rio de Janeiro. And the idea is to get more people enthused and excited about contributing to the knowledge base so that we constantly improve the guidelines that we follow when we're taking care of patients. So I'm going to end this talk with an optimistic slide. This comes from Jane Addams, who is a philosopher and physiologist at the turn of the 20th century. And this is what she said. What, after all, has maintained the human race on this old globe, despite all the calamities of nature and all the tragic failings of mankind, if not the new possibilities and the courage to advocate them? Thank you.